Good afternoon and welcome to our AMSECT HMS Medtronic webinar. We are so excited to have all of you with us today. We know amidst all of the busy schedules that we all have professionally and personally, that time schedules are so incredibly tight. So we are so honored that you are spending your afternoon, evening, depending on your time zone, with us today, and look forward to sharing with you some new clinically relevant data and evidence that we think is so exciting and impacting patients and how we care for our patients each and every day. So thank you for joining us. We're going to start with a quick Slido to test the technology, as well as to get some feedback from all of you. If you would go to slido.com and enter the code there, 1876019, or you can scan the QR code on your screen and respond to which part of the team, or what is your defined role at your current institution. A minute here to go ahead and finish logging in and responding here. This is exciting. Fantastic. Well, it looks like we're running a race here between the chief perfusionist and our staff perfusionist. A large representation from industry there, as well as some student involvement. So that's really exciting. We at Medtronic love our students and love helping partner to educate and participate with our next generation of perfusionists. So we're so excited that you're here and joining us today. Introductions briefly. So I will be helping moderate. My name is Ashley Walzak. I am the Senior Global Product Manager for cardiac surgery, and specifically with the HMS Plus, as well as the Autolog IQ. And we'll be accompanied today as a moderator with Ben Smith, who is our Senior Clinical Consultant. And Ben graduated from the University of Missouri and began his career as a medical device and clinical support rep in St. Louis in the CV space. He was then hired by ITC Hemocron to manage a team of direct reps and clinical specialists before he was promoted to the Hemocron National Sales Manager. In 2010, he became an independent clinical rep in Northern California, selling CV instrumentation and clinically supporting the Medtronic HMS throughout the West Coast. In 2020, we were lucky enough to hire Ben full-time as the HMS clinical specialist to support the field and drive new conversions. In 2021, he moved to Minneapolis with his wife to enjoy snow 10 months a year. So we're very thankful to have you with us today, Ben. And Ben will be moderating our Q&A session at the end here. A quick agenda. So we will be doing an overview of the HMS Plus, as well as then having Dr. Khan review his most recent publication of 2017, as well as the 2022 publication. And then we'll have some time at the end for Q&A. So to begin with, the HMS stands for the Hemostasis Management System, or HMS Plus. So we have 3 cartridges that we offer. The first is the HDR cartridge. The second is a high-range activated clotting time, or the HRACT. And the third cartridge is a heparin protamine titration cartridge. As we all know, hemostatic activation in cardiac surgery is very complex, beginning from the extrinsic pathway with the surgical incision, all the way into the intrinsic pathway with tissue damage and all of the activation that occurs from the cardiopulmonary bypass circuit. And all of this leads to the culmination of thrombin, which we are obviously trying to prevent during bypass. The coagulation cascade, as many of you are familiar with, I promise there won't be a quiz at the end of this, but a lot of you have spent majority of your career researching coagulation. A lot of you have just spent time through your education and through your training learning about this. But I put this up here truly as a visual to speak to really the multitude of factors that are involved in coagulation and why an ACT alone is just not enough to help us manage our current patient population in cardiac surgery. So heparin is our anticoagulant of choice for bypass, also known as unfractionated heparin. The clinical trials began way back in the 1930s, so safe, effective, and has been used for an incredible amount of time. The issue with heparin is that it has variable chain links, which leads to variability in the molecular weight and the size, which leads to variability in how we see this respond clinically in our patients. So there's brand differences, there's differences between patients, so medication exposure, their AT3 levels, their diet, whether they're on antithrombotics or Plavix, prior heparin exposure, all of these things really lead us to this variability in the response that we see in our patients. And of course, the antidote to this is protamine sulfate. So this really brings us to the question of, should we be basing heparin on a weight-based heparin dose, or should we be transitioning to a more sophisticated approach where we are utilizing an individualized heparin management protocol for our patients? Looking at specifically our heparin dose response cartridge. So this is how we really see our individual patient response to heparin. So the HDR calculates 4 different data points. So the first one is the slope of heparin sensitivity. So if the slope is low, it tells us that our patient is likely going to be resistant to heparin. If the slope is high, it tells us that our patient is likely sensitive to heparin. The second piece of information that is provided from this cartridge is the baseline ACT. The third piece is the heparin bolus, so the loading dose that you will give before going on bypass. And then the fourth thing is the target heparin concentration that should be utilized for that specific patient during the bypass run. And the way this works is through a heparin dose response curve. So the cartridge has everything runs in duplicate, but the first 2 wells do not have heparin in them. And this will give you your baseline ACT response. Oops, Natasha, can you advance me, please? So that will show that portion on the curve there. The second set of wells have a medium dose of heparin in it, which then shows you that place plotted on the curve. And then the third set of wells give you about 2.8 units per ml of heparin. And that again shows you that higher response or sensitivity to heparin. You then tell the HMS what you want your target ACT to be. So we'll use 480 as the standard. And then it tells you for that specific patient what type of concentration you need for bypass to adequately anticoagulate them. So for this patient, it would be specifically around 3.7 units per ml. The heparin protamine titration. So this cartridge is our way of getting a heparin concentration while you're on bypass, and it can be run along with the ACT, which is also again run in duplicate, again for increased reliability. It will also give you the redose amount of heparin to give if the patient is subtherapeutic, as well as your protamine dose at the end of bypass. I would now like to welcome our keynote speaker for this evening, Dr. Khan. Dr. Khan is the Director of CV Services at Alta Bates Summit Medical Center in Oakland, California. He graduated from UCLA Medical School and did his general surgery and thoracic surgery training at UCSF. He is the immediate past president of California STS and the past president of Northern California AHA and ABSMC. He is particularly interested in minimally invasive mitral valve repair and has worked on blood conservation strategies throughout his practice. He has authored numerous publications, including Best Practices for Minimally Invasive Mitral Valve Surgery and original research in JACT regarding blood conservation with the HMS system. He is an avid scuba diver with his family, and he just returned from an incredible vacation with his family to be here with us tonight. We are absolutely honored to have him. Dr. Khan.
Thanks so much, Ashley. Natasha, can you give me control?
You should have control.
Let me know, Natasha, when you think I should have control.
Try again now.
I'm not seeing the arrows to advance like I was before. But I'll tell you what, I'll get started. And then if I don't see those arrows and if my return enter key doesn't work, I'll ask you to do it. How's that? So welcome to everybody at AMSAC. I wish we were in person. One of my favorite meetings is when I was at AMSAC presenting our initial data, which we'll talk about. And I remember I had some of my best cigars at that meeting in Rome, thanks to Ben. So we're going to talk about blood conservation as a quality outcome. And you know, blood conservation is not necessarily a sexy topic, but it's a really important topic. And it's really a programmatic item is what I tell people. There's no one machine or magic bullet that you can take that's going to fix your blood transfusion or blood conservation item. But you know, how to enact an intraoperative change by using the Corteva-coded affinity fusions and HMS monitoring system is what we did at our institution. And I think our institution is sort of relative for other institutions, and then you can use that as an example as you move forward. No, Natasha, I'm not going to have control, so I'm going to say next slide to you, okay? So disclosures, I am a consultant for Medtronic as well as the companies. Any patient data that's here is that releases are on file. Next slide. So first, the most important thing is to know who's giving the talk, right? What does this represent per se in terms of who is presenting the data? So we're at a tertiary center in Oakland, California. There's 3 surgeons. We do about 400 hearts a year. We do a lot of minimally invasive mitral surgery. We have an active MitraClip program and a TAVR program, about just under 3,000 cats, and diverse population. And I think you guys can see my arrow. What I can tell you, this is our hospital, but just off the end here is a patient base where we do probably 25 to 33% of our patients are relatively small Asian women. That means under 40 to 50, 50 kilos or under. And as you know, that is a notoriously very hard patient population to avoid blood on. And I think that was sort of one of the biggest motivations we had. I was doing these great minimally invasive mitral cases in these 40-kilo women, but we were ending up transfusing a high rate. And as you'll talk about, transfusions aren't free. I'm not talking about economic cost by itself, but the complications and things along the way. Next. So this is a Pareto diagram of the distribution of non-autologous blood units transfused in just under 5,000 patients. What you can see here is that most patients actually get through without using any blood. But when patients need blood, 10 units or more are utilized in a small percentage of patients. So a small percent of patients really get out of control. And that's really where some opportunities are. Next slide. Oops, sorry, go back one. Okay. So why do we care about blood transfusions? Currently, it's a CMS quality measure, which is Medicare. For those of you, I see in the chat, there's a bunch of people from outside the United States. That's Medicare. That's our public insurance platform. And they actually do look at it as a quality measure for cardiac surgery programs. Blood transfusions are linked with increased morbidity and mortality in patients. The deleterious effects of blood transfusion increase on a per unit basis. And what that means, this is really not so relevant for the perfusionist per se, but we are unable to order 2 units of blood to give to a patient. We have to do it 1 unit at a time. And that sort of just re-emphasizes that each unit has its own morbidity and mortality associated with it. Now, I'm not talking about someone who's hemorrhaging in the ICU. I'm talking about in general, if the hematocrit or hemoglobin is low, we will still give a unit of blood, check, and then give a second unit of blood. Now, it's only a matter of time. In California, like every year, you can look up my my name in the local newspaper, and it'll have my mortality listed. It's publicly reported. And it's just a matter of time before blood product usage is going to be able to be reported. Similarly, reimbursement will eventually be tied to quality measures, with blood being one of them. And obviously, blood transfusion costs the hospital a significant amount of money. Okay, next. So the most important thing that you should take away is you should independently review the 2021 guidelines from the STS, SCA, AMSEC, and SABM update on the clinical practice guidelines for patient blood management. Most of this was really an update from the 2011 guidelines, but there were some additions to 2021, and we will review those here. Next. So in both guidelines, heparin management for patients requiring longer bypass times, greater than 2 to 3 hours, it is not unreasonable to consider maintenance of higher or patient-specific heparin concentration during cardiopulmonary bypass to reduce hemostatic system activation, reduce consumption of platelets and coagulation proteins, and reduce blood transfusion. Protamine dosing. It is not unreasonable to use either protamine titration or empiric low-dose regimens, for example, 50% of total heparin dose, to lower the total protamine dose and lower the protamine to heparin ratio at the end of cardiopulmonary bypass to reduce bleeding and blood transfusion requirements. The reason for this is, as you know, protamine itself is an anticoagulant. Bypass circuits, heparin-coated bypass circuits, either oxygenated alone or the entire circuit, are not unreasonable for blood conservation in cardiopulmonary bypass. Prime volume, it is not unreasonable to use low prime and minimize extracorporeal bypass circuits to reduce the fall in hematocrit during cardiopulmonary bypass as part of a multi-modality blood conservation program. So I can't emphasize this enough. There's nothing that you can do, any individual can do, to make a difference. It has to be part of a team approach. So when we started on this process, we got anesthesia, nursing, perfusionists, and our intensivists, our ICU nurses, everybody, all the stakeholders in the loop to make this program work. A comprehensive multimodality blood conservation program led by a multidisciplinary team of healthcare providers should be part of any patient blood management program to limit blood utilization or blood resources and decrease the risk of bleeding. Next. Okay, so this is our next slide of question. Blood transfusion is a CMS quality metric for cardiac surgery programs. True or false? I'll give about 30 seconds here for people to answer. Okay, great. That's exactly right. So blood transfusion is a CMS quality metric. Again, for the people outside the United States, CMS is Medicare, which is our public healthcare for people over 65. It is really no hospital can survive without Medicare in the United States, and CMS quality metrics are a major driver for funding for the hospital. So blood transfusions are a metric for CMS in cardiac surgery programs. Next slide. Okay. So this time we'll ask the question first, and then we'll talk about the data. Percent of patients with any serious complication after cardiac surgery who have anemia and any transfusion. Percent of patients with any serious complication after cardiac surgery who have anemia and transfusion. Okay, that's fantastic. I think most of you got that right. It's 38%. I will tell you, that's a lot higher. That's a lot higher than I think most people think. So this group, obviously being perfusionists, is pretty sharp about this, and they know that 38% of patients with any serious will have any serious complication after cardiac surgery who have anemia and transfusion. I think if you'd asked me that beforehand, I would have guessed a lower number myself. So here's the data right from the AMSAC STS guidelines from 2021. So any serious complication is up here in purple at 38%. You can talk about transfusion only is still over 30%, and anemia only is down here by closer to 10%. And the reason I think it's either anemia and transfusion is when I give this presentation, sometimes people really focus on how low will I let the hematocrit or hemoglobin go before I give blood. Well, I think if you think that way, you've already lost the battle. I don't really try to focus on how low I'll let the hemoglobin go before I give blood. The focus really is on how to not let the hemoglobin get low in the first place. Now, we do have certain parameters for transfusions that are relatively tight, and we're cognizant of it. We give 1 unit at a time, like I said. But really, my main focus is to prevent the hemoglobin from getting low, not focusing on letting the patient be anemic. In terms of any pulmonary complications, you can say the rate is about 25%. Unplanned surgery is about 20%. It actually has a direct impact on operative mortality, sepsis, wound infection, renal failure, MI, and even CNS. So it's a really significant issue when you have anemia and transfusion of any products. Next. So when we were looking at the 2011 guidelines, we looked to see if Altabate Summit Medical Center could implement a multimodal strategy to reduce and track the impact of blood utilization. Next. So this is our overall timeline. We started sort of in phases, partly because we wanted to see the impact of each individual item. And what I can tell you, first we used a reference period going all the way to 2014 to 2015. We included all patients. The only exclusion was dissection cases. We did not use type A aortic dissection cases because, quite frankly, in my hands, I don't think it's rare for me to do a type A without blood. And we wanted to be consistent throughout the study period. So we excluded the patients with type A aortic dissection in the study, but included them in all other patients, including re-ops, were included. First, we included the oxygenator here, starting in 2015, in June 2015. And then we started in 2016, the HMS system. Our initial publication was in 2017. And then we had an extended follow-up period, and that data was published in 2021. Next. So here's our initial study, which is the blood and blood product conservation results of strategies to improve clinical outcomes in open heart surgery patients at a tertiary hospital. And this was presented at the AMSAC in 2017. Next. So we retrospectively looked at from 2014 to 2016, all cardiopulmonary bypass patients. The number was 718. We reduced cardiopulmonary bypass circuit prime volume. We switched to the Affinity Fusion oxygenated system. We switched to Affinity CP, reduced the tubing and its components, and reduced venous line from 1/2 to 3/8. And then we implemented the HMS Plus from ACT only. Next. So the results were actually quite surprising for us. In the beginning, we were using about 56,000 units of heparin. After implementation, there was a dramatic drop. The p-value was less than 0.001. And if you read enough papers, you know this is very significant. We dropped our units down to 43,000 units. The oxygenator was introduced right here. In the protamine dosing was reduced from 340 to 180. You'll see that the ratio of drop in protamine is actually greater than the ratio of drop in heparin. That means the protamine dosing was more significantly reduced than the heparin dosing. And as I told you earlier, you have to just remind yourself that protamine in of itself is an anticoagulant. And again, it was very statistically significant. Next. Our platelet administration dropped very significantly from the introduction. As you can see, we were starting to looking at this and become more careful right here, but that trend line continued pretty dramatically here. And again, the p-value was very significant. We went from using over 1/2 a unit on average down to about 1/10 of a unit on average in terms of platelet transfusion. Our number of packed red blood cells also reduced dramatically from 26%. And if you think this is bad, that we're bad. We're not. We're average for the United States. And that's not necessarily a good thing, but where we ended up was 8%. And this was with the oxygenator and the HMS system. And again, this was statistically significant. Next. In terms of ICU length of stay, what I can tell you, length of stay is quite hard to demonstrate in terms of statistical significance. In terms of hours in the ICU, we did see a length of stay decrease across the pathway, but it was not statistically significant. And that is multifactorial. It has to do with a lot of issues in terms of what times the patient can leave. So there was a trend line in reduced length of stay, but not statistically significant. Next. So the next item we wanted to look at is, were these results sustainable? We saw them in the initial data, but they're sustainable. So next. So the question I have for you, what is the Hawthorne effect? If you can answer that in your Slido. Okay, great. Next. So most of you got that right again. It's an alternation of behavior by subjects of a study due to the awareness of being observed. Next. This is the Hawthorne factory in Cicero, Illinois, Western Electric. And I think what we learned there is that, when in the operating room, when we have an audit going on, everything is always perfect. When people know that they're being watched, everybody is on their best behavior, and things improve just by the fact when people know that they're being watched. And in the case of the Western Electric Company, it was safety and output. In terms of surgery, it can be blood transfusion. So if everybody knows that we're really tracking blood transfusions, people will be more cautious. My partners will have their chest more dry before they leave. But the one other thing about the Hawthorne effect is it can't be maintained for long term, meaning it is a short-term effect, not a long-term effect. Next. So what we wanted to do is really see, okay, we got these great results. Everybody knew that we were watching, including myself. We were really on top of it. Every pre-op nurse, ICU nurse, OR nurse knew that this was a major focus for us. But we wanted to see if we could maintain that benefit over a 4-year period. So we took that same, our patient population, and watched it over the next 4 years. Next. So we looked at data from 2017 to 2020. Again, all patients who underwent cardiopulmonary bypass. The only exclusion was patients who had type A dissections. We had just under 1,000 patients. Next. What we saw was an 18% reduction in blood packed red blood cell administration was maintained 4 years later. That is not the Hawthorne effect. Next. So what you can see, we saw this drop down to 26, to 22, and then down to 8%. There was a little bump up to 11, but we certainly did not get back to 26. So maybe the 8.8 was a Hawthorne effect, but we settled in a nice rate of under 10% here for the long haul, just around 10%, which is dramatically better than the 26.7 we had for years before implementation of HMS and the affinity system. Next. Similarly, the reduction in platelet administration was maintained at 36%. The first FFP reduction was maintained at 22%, and cryo reduction was maintained at 27%. And this talks about not just anemia, but that slide that Ashley showed you earlier about activation of coagulopathy that occurs with surface activation, direct and indirect. That means that by using the affinity system and by using HMS, which reduces protamine greater than it reduces heparin, we're actually decreasing the coagulopathy or the surface activation or the stuff that causes bleeding to occur. Next. Our heparin and protamine dosing is reflected here. if you'll recall, there was a massive, during these years here, there was a massive change in heparin vendors, particularly in the United States. I can tell you from this period of time, we actually went through 4 different vendors for heparin. And our ACTs were all over the map because of the potency of the heparin we were getting from various vendors from out of the country. It's interesting that our heparin dosing has continued to decrease. We're not exactly sure why it's continued to decrease, but the protamine dosing decrease is actually still remains a more significant decrease than the heparin dosing. Next. Intensive care and hospital length of stay. What you can see here is length of stay did come down and has stayed down, but it's so multifactorial that we have not been able to maintain a statistical significance. What you can also see here is ICU hours have also not only come down, but stayed down. But again, we were not able to maintain a statistical significance because there's so many other variables involved here. Next. So cost. The hospital is always interested in cost, and quite frankly, I'm always interested in cost. I don't think it's a bad thing to be worried about cost. I'd much rather have an extra physical therapist or an extra nurse to help to get the patient out of the bed than anything else in our system. Just with the oxygenator upgrade, we had a 24% blood product cost reduction. The savings in terms of the total hospitalization, because blood is expensive, was 7% of the total hospitalization. Based on the internal hospital blood acquisition cost, that was about a $2,000 savings for the hospital. Average total hospitalization cost saving, based on the American Hospital Association, was between $10,000 and $13,000. When we implemented HMS Plus Affinity, the percent blood product cost reduced by 61%, reduced the total savings of the hospitalization by 8%, $5,500 acquisition cost savings, and a total admission savings of between $11,000 and $15,000. I can tell you, I meet with our CFO regularly. This definitely gets her attention. So not only is there a morbidity and mortality cost, but there's a pretty substantial cost saving for the hospital as well. Next. So in looking at it very long term, was the cost savings maintained? What I can tell you initially, in our initial data, 61% reduction in blood product cost savings. We saved on average $5,500. Percent saving of the total hospitalization was 8%. And again, we maintained between 11 and 15,000 savings. For 2017 to 2020, percent saving reduction maintained at 36%. We saved about $2,300. Part of this was, if you'll remember, this is during COVID time, our blood costs went up dramatically during that period of time. And one of the things that we did do is we reduced our PAR level once we gained confidence in the reduction of blood and blood products. So let's say if we needed to keep 6 platelets in-house, we reduced that down to 3. If we used to always have 4 units of blood, we reduced that down to 2. All that saved money for the hospital and really helped us when there was a significant blood shortage during the COVID period. The average savings over an extended period of time was $2,300. The hospital savings was maintained, and the average savings for the total hospitalization was between $13,000 and $16,000 based on data from the American Hospital Association. Next. Okay. Intraoperative implementation of cardiopulmonary bypass circuit upgrades in the HMS Plus system led to an intraoperative blood product usage reduction and overall trend towards lower ICU time and length of stay. So 67% total reduction in intraoperative blood red cells, 15% of that occurred during the oxygenator, and 61% of that occurred during HMS. I truly believe that that has to do with the greater proportion decrease in protamine dosing compared to heparin dosing. 56% perioperative and 80% intraoperative reduction in platelets, 23% reduction in heparin dosing, and a 46% reduction in protamine, and reduction trends in ICU and length of stay. Next. Cost savings, $5,500 for the blood products, $13,000 for the hospitalization. That is not small potatoes. That's really pretty significant. That enough pays for an extra physical therapist or an extra nurse per shift to help mobilize the patient, in my mind. Next. So overall, the advantage of the system, using the HMS system and the Affinity, there was a benefit for the patient in terms of reduction in morbidity and mortality. based on, we talked about, there's a 38% incidence of morbidity and mortality associated with transfusion and anemia. There's a benefit for the surgeon. I like having a dry field. I like not being called for bleeding or having to give blood. And the benefit for the institution was really reduced costs and reduced trends in length of stay. You have to have engagement. This is not something a surgeon can do. This is not something a perfusionist can do. You have to do it together. You have to get your anesthesiologist in the loop. You have to have pathology, which runs the blood bank, in the loop. The point of care testing that's required, the nursing from the same day surgery in the pre-op area. If they give the patient a liter of blood, a liter of saline before they come into the OR, well, you've already lost the battle. So it really requires a multi-modality approach. I think one of the things I really liked is initially we thought we were imagining things, but clearly patients are drier when they hit the ICU. We can see that we've caused less contact activation when we used heparin-coated circuits, affinity, and HMS. Impacted delivery of less protamine and less bleeding. Next. Ability to use known heparin concentrations to initiate bypass. It's a huge advantage, I think, for our perfusionists. We've seen less hemodilution as reduction in intraoperative transfusion of all products. So again, I'm not trying to get to what is the lowest hematocrit or hemoglobin I'll tolerate. I just want to not get to that spot by avoiding hemodilution. The benefits using the HMS in cardiopulmonary bypass cases under 2 hours is seen by transfusion level reductions for red cells, platelets, cryo, and FFP. So across the coagulation cascade, and realized reduction in hospital costs and costs to the patient. Next. Now, in terms of our current practices, I sort of put a slide or two in because these are the most common questions that the perfusionist asked when we gave these presentation. There you go. There's a perfusionist. Perfect timing. So our target ACT is 480 seconds or above when we start. Our heparin dose is based off a patient heparin dose response taken as soon as an arterial line is placed. The most significant part of this is that we know early if we're going to need AT3. That means it's not after I've harvested the internal mammary artery and then we're waiting and waiting. We don't keep AT3 up in the OR. Maybe some people do. It's got to come up from pharmacy. So now, right after the patient's in the OR, they know if they're resistant. And if they're resistant, they'll order the AT3 much earlier. The target heparin level for each patient is maintained at a minimum of 2.5 milligrams per kilogram of heparin. Next. In terms of our AT3 protocol, it's all based off patient predicted heparin sensitivity, which is done by reading the slope of the graph of the first patient sample run on the HMS. That's done as soon as our arterial line goes in. A slope of 100 is normal. For us, a slope of 75 to 80, we give 1 vial of AT3 prior to heparinizing for cardiopulmonary bypass. Slope of 75 or below, we use 2 vials of AT3. The HMS Plus has been very valuable in predicting which patients will need AT3. Ironically, we've actually used a little more AT3 over the last few years than we did before, as we've recognized heparin resistance. Before, we would just give more heparin and sometimes just get by with the minimum ACT and worry about it doing the case. Now we know, based on the HMS system, which patients are going to be resistant. Next. Our protamine dose is based off the HMS Plus result. The HMS Plus has also lowered our heparin protamine use during these cases. The most important part of this is, I've said this many times before, and I'll say it again, it's important to know that protamine is an anticoagulant. I think the single one item I would say take away from this is that our protamine dosing has been reduced more than our heparin dosing. And I think that has been the greatest impact of using the HMS system and reducing the coagulopathy that we've used to have, reducing the hemodilution we used to get with giving products, then chasing our tail with giving packed blood cells. So this has been a very significant impact. Next. So we're right on time. So I'll finish up here with blood and blood product usage in cardiopulmonary bypass patients was analyzed over a longer period of time in this study to evaluate whether our previous observations published in 2017 were due to the Hawthorne effect. Implementation of advanced cardiopulmonary bypass technologies helped to reduce blood usage because of less trauma to blood cells. HMS Plus reduced usage of heparin and protamine, even to a greater degree. leading to less transfusion of red cells, platelets, cryoprecipitates, and fresh frozen plasma. The benefits previously observed were maintained in a different population for the next 48 months. Next. Here's some references if you guys, and your local rep can make these available to you as you go forward. And then I think what we can do, Ben, we can do the Q&A at this point. Thank you so much for your attendance.
That's fantastic. And thank you, Ashley, for the great review of what HMS does, and Dr. Khan for the clinical impact. And I get so much hearing about it. I always learn more, and it makes me think critically about open heart surgery and its entirety. And I can't help sort of resting on the fact that at Summit Hospital, it was a multi-modality approach. It wasn't the one improvement hopefully will lower all aspects. You did have a tremendous amount of improvement in such a variety of attributes. What was the main driver and the initial, who took sort of the initial interest in correcting and lowering some of the matrix, such as blood products and length of stay and cost? Was that a corporate decision, or was it really you with corporate creating this initiative almost hospital-wide?
Yeah, Ben, that's a great question. I think there has to be a champion for this to work. And I wish I could tell you that I championed this process from some great scientific reading or review. What it really was, anecdotally, as I said, I do a lot of minimally invasive mitrals. I do a lot of minimally invasive mitrals in a relatively small Asian women population. And I was tired of those people being anemic, requiring blood, and some of them having, the surgery went great, but they had a blood transfusion, not necessarily a blood reaction, but a complication that was probably related. As you saw, 38% have some complication associated with it. And you take a perfectly great minimally invasive operation and it changes that focus. So I think that was really the push for my minimally invasive patient population. And then what I did with that is I really partnered with our perfusionists, because we needed to know how this was going to work. And then once we did that, we were able to actually get administration on board. I will say that the clinical push was the real push, is avoiding morbidity and mortality. We were very pleased to find the cost savings. The cost for implementing the program in terms of actual cost is not tremendously high. What is high, it takes a time commitment from a multimodality team, and convincing them, I thought, was the biggest challenge. But going over the data, going over the STS, MSEC guidelines, we were able to get everybody on board.
That's tremendous. Did you get any sort of pushback from anesthesia? Just dosing tends to be their sandbox and what they do. Did you get any pushback from them, or did you have to do a multitude of cases to say this is actually working well?
Well, getting pushback from anesthesia is almost a rhetorical question, right? No, I think we have a great, I'm very fortunate. We have a great partnership, primarily due to our minimally invasive program, with our anesthesiologists. Honestly, that for us, all politics is local. You have to work with your local people. Our biggest pushback was the QA aspect of the machine. From the Joint Commission review, just checking the boxes, dotting the I's, crossing the T's, making sure that when a Joint Commission survey was done, this was a new process for the perfusionist, so they would do that part of it. I think the anesthesia issue, I think they were thrilled as to not ever having to wait for AT3 to come up and knowing what the heparin sensitivity was. They were very happy with the quote unquote drier field. The challenge is really using smaller IV bags. Is that really help, or does it not help? I'm not sure how much it actually helps from a truly volume standpoint. I think using smaller IV bags helps as a visual reminder that all that stuff matters to everyone. Our patients are quote unquote special. So it's not like if you're doing a hip or you're doing a hernia, you're going to use small bags. You're going to make sure you don't hemodilute the patient starting in the pre-op area. So I think our anesthesiologists were fully on board, and we've had a good working relationship before, and they were good partners for us with this.
That's tremendous. I'm getting many chat questions come in, both in the Q&A as well as the normal chat, about your target of 2.5. You had mentioned 2.5. Is that the minimum that you maintain your patients coming at 2.5? So you would have perfusion increase the heparin and the target up to 2.5? Should the initial dosing cartridge recommend lower, or do you keep everyone at 2.5?
No, that's exactly right. That's exactly right. I think that's the minimum, and we'll go more if needed. There was one chat question that comes in that surgeons often ask for protamine if the field looks wet, no matter what else is going on. I would put myself in that category for the first decade. And it was primarily because I forgot what I learned in medical school, that protamine in of itself is an anticoagulant. You're shooting yourself in the foot by doing that. Now, you're probably not going to convince your surgeon per se in the heat of battle. That's why it's not a discussion to be had during surgery. It's a discussion, honestly, I think my perfusionist, I give him a lot of credit. He actually came to me in the office and we had that conversation about protamine being an anticoagulant and the fact that, look, it's not going to work. If anything, it's going to make it worse. And then we looked at data, we talked about it at our meetings, and it's, not in the heat of battle, but, after the case is done, down the line, you need to sit down and just remind them that it's an anticoagulant. It actually, if anything, it's going to make things worse. Now, and also part of that is, do I believe the ACT? Where and what is the lag time in ACT compared to how much cell saver you're giving? There's a lot of things. I think knowing a specific heparin level of 0, it just gives me greater confidence than knowing, giving protamine is just might as well throw water in the field. It's not going to make any change because the heparin is gone. Your bleeding is from something else that you have to fix. I think that once you develop, so it won't be overnight, but once I had the confidence of when they told me HepCon is 0. Now, what I will tell you, of course, initially I didn't believe it, right? The HepCon being 0. But what finally convinced me is there was a couple of cases where we had a lot of cell savers, and we tested the heparin concentration after cell savers. And actually, after testing, it actually went back up. So it was consistent with what I would expect. And I think doing those internal checks and being intellectually honest with yourself really made me believe in the HepCon 0 being 0.
That's fantastic. That's really great. Kind of switching to protamine side, there's a lot of discussions when I travel coast to coast around about the heparin protamine ratio. And do you all do a 1-to-1 heparin to protamine ratio, meaning whatever final cartridge to grab your protamine dose indicates, that's based on an equal amount of heparin that is identified as circulating, or do you lower it at all?
I think if anything, we're going to be on the lower side, but generally we will give the protamine recommendation that HMS Plus tells us, because I think generally that's been really accurate. So I don't think we start with half dose. We give the dose that the HMS Plus system recommends. It's been really spot on for us in our experience. The variability we've seen is with the heparin dosing more than with the protamine dosing. I don't know how much of that has to do with all the various vendors we've had. We've really had dramatic differences in heparin potency over the last 5 years. The protamine potency has been relatively consistent, for lack of a better word.
Yeah, you're absolutely on point. When I travel, I hear a lot of, don't use the heparin brand A, use B or C. The A we discard because it's just it's much less efficacious. Do you get any sense from perfusion that as you're operating and they're running the show behind you, that the heparin has a shorter half-life today more than it was back in 2014? Do you find they're having to redose?
Yeah, absolutely. It definitely does. And I think that's a great ongoing communication we have with our perfusionists. And I think they have been fantastic. The perfusionists have been helping identify the anesthesia, which brand, A, B, or C, and how that may be different. And particularly, I would tell you in the beginning, we wouldn't even look at the brand. Now, because the perfusionists track it, they know, oh, this brand really has been problematic. But the most important thing is, honestly, knowing that I have a certain heparin concentration is it's really a comfort compared to giving a dose and waiting for the ACT. Because again, it's all about, I have to have 2 cases done by 3 o'clock or it's not going to work. My program is not going to work if I can't. And in all those little delays that add up and waiting for ACTs, giving more heparin, waiting for AT3 to come up, don't work in a programmatic fashion for us.
Do you go on pump when the ACT is above 400, or do you lean more on the concentration and then turn on suction?
So we use the concentration now. In the beginning, we waited for the ACT, but now I think after years of knowing that the heparin concentration comes back usually sooner, and honestly, perfusionist is not going to listen to me. He's going to do what he's comfortable, right? So they have become comfortable with the heparin concentration.
That's fantastic. It took a while. I remember the days of you going live and talking to anesthesia, and it was a really great time because the improvements that you saw. That I remember noticing you and Dr. Stanton talking about the dryness that you saw, and that really hits home in hearing that live back as you first started using this. Can you speak a little more on what you notice as drier? I mean, it's sort of a general. Is it more in the anastomosis sites, or is it as they're closing?
Yeah, it was generally speaking, if something is too good to be true, it's not going to be true. But when we started doing this, we were really, it was quite particularly after we got HMS going, it was usually when we do studies, we have to wait for the data to come out and be analyzed to see the difference. In this particular case, we started noticing the difference fairly early on, particularly after we implemented HMS. And I really do think it was because the protamine dosing was so much less in the beginning. It was a dramatic reduction. And it's what we call the biggest difference we saw was quote unquote needle hole bleeding we talk about, and also just oozing, which is the kind of surface activation, extrinsic pathway coagulopathy that you see. That I was just noticing that we were using fewer. I know what time my tech usually asks for an extra pack of laps. They weren't asking for those laps. That means we weren't going through them at the end when we were closing in that process. So we noticed that our closing times were getting a little faster because we actually tracked each portion of the case. Now, sometimes you're impatient, you're closing faster, but if you're doing that consistently over a quarter, then something else is happening. And it really is because the field was quote unquote drier. I still didn't believe it until the data came out, but we definitely noted it. We talked about it. Anesthesia noted it.
Excellent. Well, we've got time for really one more question as this is a fantastic discussion. And I see that some of the questions are about your multimodality approach. Do you use, I forget at Summit, if you're using a TEG or a Rotem or any other device post-operatively to help you get a little guidance on blood product?
So we talk about TEG every quarter. We have not implemented it yet. Okay. It's one of those things that is going to be anesthesia driven. It has to do with the number of QA and cost issues, but we were about to do TEG when we did HMS. And frankly, we saw such a great benefit that we actually stopped the process of implementing TEG to see it because we wanted to see how this was going to play out. And I'm going to go back to the dryness. Surgeons can deceive themselves one way or the other. We use an average of 8 laps less per case today than we did in 2015. Everybody knows what a laparotomy pad is, right? So that is what it is. That is really laps you really use towards the tail end to dry up. We use about 8 laps less per case now.
That's tremendous. Well, thank you for this discussion. We could have you on for another 4 hours if you're not busy. That would be great. But unfortunately, we have to wrap this up. Ashley?
Yeah, thanks, Ben. Fantastic questions. I apologize we weren't able to answer all of them. I think this also lends itself to, the many complexities to HMS. So I would encourage those of you who might have questions that were not answered to reach out to your local sales rep, and they will be able to connect you with those answers, or someone like myself. I'm happy to help with those as well. Working out how you implement this in your center and what that looks like for your patient populations with your surgeons, your perfusionists, and all of that. So thank you, Dr. Khan. This was fantastic. Just great clinical evidence for us to really make an impact on our patients and how many blood products we're administering, and really enlightening to see how our heparin management is really linked with that. So thank you for your time this evening. We are honored to have you as our special guest this evening. Thank you to AMSEC for their support of this, for helping us set up the webinar, and thank you to our Medtronic team and marketing, communication, training, and education, and Natasha's on here. So thank you so much for your support of this. And thank you to everyone for your attendance. We're excited to have you as part of this and excited to continue this conversation. Hope everybody has a wonderful evening and a great rest of your week. Thank you for attending.